Thank you. This is an issue that I think pediatric pulmonologists sometimes are faced because so many children, so many adolescents, both boys and girls, are in athletic activities today. And the child, the adolescent, and often the parents want to know what's the reason that some of them are having inappropriate dyspnea on exertion. Let's watch Homer right now. Turn the volume up. Higher.
As high as it goes, I'm afraid.
Huh?
As high as it goes.
High it goes, okay. All right. Well, this cartoon, Homer, is an example of someone who couldn't go very far without feeling short of breath. And this is what a pediatric pulmonologist is sometimes faced with. The child wanting to compete successfully in the activities, both boys and girls, and actually there's a slight excess of girls today because they're very much involved, as much as boys, with physical activity. Can you, everyone in the back, hear me? Okay, good. So, of course, the most common cause of exercise-induced asthma by far is asthma. And this is a classical 6-minute exercise test with initially some adrenaline-sponsored, adrenaline-affected. No. Please go back. Back. One more. Okay, good. You're fine. Okay. So this is a classical 6. Go back once. Yeah. Okay, this is a classical exercise test with. Am I pressing the wrong thing here?
Using the clicker if they're manipulating it.
I think that's a clicker and a pointer as well.
Okay.
Sorry, pass.
All right. Classical exercise, 6 minutes exercise, initially some bronchodilation, and then after the end of the exercise, a precipitous fall that either reverses spontaneously or with bronchodilator. However, this is easy to diagnose because it's readily blocked by a beta-2 agonist, and we're all familiar with that. There are some that are more serious than that. Here is a young lady, an adolescent, standardized exercise test. She could only complete oh, there we go. She could only complete less than 3.5 minutes. It had to be aborted because of severe dyspnea and wheezing. Albuterol was given, and then so she had trouble even with casual activity, not just athletic activity. Now, you're all familiar that vocal cord dysfunction has imitated asthma in some cases. That was a New England Journal of Medicine article from a number of years ago. This is one. This was the first study of vocal cord dysfunction presenting as exercise-induced asthma. written by a Regis McFadden, who was a very prominent pulmonologist at the time, and he was interested in why these 7 elite athletes were having dyspnea on exertion and interfering with their activities. They did not have asthma. He determined that. What they did have was, during exercise, they had a marked decrease in the inspiratory flow of their flow volume loop. And he interpreted this as being from vocal cord. However, so he diagnosed that as vocal cord dysfunction, just based on the flow volume lobe of this patient and a few others. However, that physiology of blunting of the inspiratory flow volume loop could also be from laryngomalacia. And unfortunately, with his study, although I know Regis McFadden, he's very good, but in his first study, he only did laryngoscopy in 3 of the patients, and only 4 of the 7 showed inspiratory obstruction, like you see in that. And so, although he didn't consider it at the time, the 3 of the 7 assumed to be vocal cord dysfunction, but without any supporting data, is just because he found that in a number of patients, he figured all of them must have it. But as I'll show you, it gets a little more complicated than that. I'll learn how to use this properly before the end. So I'm going to show you a very definite girl who did have vocal cord dysfunction, and what it takes to determine that's what it was. This is a 15-year-old girl with 3 weeks of what they call wheezing, and of course, non-physicians, ordinary people call any respiratory noise wheezing, and it was really an inspiratory noise. And she had dyspnea on exertion, no prevention from pre-exercise albuterol, so it was not asthma. There was no response to any asthma medications. They tried a few. And here's her flow volume loop before and after exercise. That's pre-exercise, and here's post-exercise. So this is classical extrathoracic obstruction, perhaps at the vocal cords, but not necessarily. So just reviewing her, this was a treadmill exercise, induced the stridor. She had normal pre-exercise as shown, and this is diagnostic of extrathoracic airway obstruction. So is there extrathoracic airway obstruction due to vocal cords? Well, for that you have to look.
Can you see over your shoulder at all?
I know, okay.
Okay, now open your eyes and look in there. Okay. As we are breathing there, would someone point to her and show her vocal cords? Swallow. Nice slow deep breaths. Okay. Now you notice when you exhale, they open up. And when you inhale and make a noise, you see how they're going together? That's the problem. They're supposed to open when you inhale. Okay? Why don't you say something and make them move?
I.
Okay. Are you looking at it? Okay. Say 1, 2, 3.
1, 2, 3.
Okay.
And we found from examining a number of kids who did have definite vocal cord dysfunction based on visual confirmation, not just on the initial physiology, which might be vocal cords, or could be other causes of extrathoracic airway obstruction. And we found in this particular study, we found that ipratropium in the form of the U.S. product, Atrovent meter dose inhaler, blocked this. Now, this has not been done in a controlled clinical trial, but when we got the idea, we had 6 patients who got ipratropium, totally blocked their vocal cord dysfunction, and we looked at previous 6 patients where we hadn't used it, and they were continuing to have problems. Albuterol is not effective for this. So from the observation of the patients in this particular study of vocal cord dysfunction and our continued clinical experience, without controlled data, we still feel this has become the treatment of choice for actual vocal cord dysfunction, exercise-induced vocal cord dysfunction. Ipratropium seems to block it. Now, I mentioned that the extrathoracic airway obstruction could be laryngomalacia. And this was a nice study done in 2005. And here you see inspiration and expiration. And on inspiration, there's invagination of the arytenoid that can be essentially sucked in during inspiration and cause upper airway obstruction. This is not nearly as common as vocal cord dysfunction, but it does occur, and the treatment is very different. And the only way you can tell the difference between them is to look. You have to look at the airway in order to determine that. And in this particular study, they demonstrated what an ear, nose, and throat specialist could do with a laser, and, well, that looks very ugly. In fact, a couple of weeks later, it was healed and looked just fine. So that is treatment, and this is why it's important to look, because it's just a small number of all the patients with extrathoracic airway obstruction that will have this excessive floppiness of the arytenoids that are not a problem with quiet breathing, but during vigorous exertion, they get stridor, and they have physiology that looks the same as vocal cord dysfunction. And there have been quite a number of reports of this. Now, there's continued interest in the upper airway. This keeps disappearing. In the upper airway as a cause of exercise-induced dyspnea. And this is a study that looks like they were trying to come up with a different method for identifying it, and they wanted it to be the same on both sides of the Atlantic. And they said that exercise-induced, they talked about exercise-induced laryngeal obstruction, which is essentially one form of extrathoracic airway obstruction. And they say in this article, a nonsense statement, a condition previously known as vocal cord dysfunction. That is stupid. It's just dumb. Vocal cord dysfunction is a specific abnormality that you saw a picture of. And exercise-induced laryngeal obstruction might involve more than just the vocal cords. Oops. Sorry. I don't know what happened. Okay, so EILO is, let me just see if I had anything before this. Yep. EILO entered our lexicon, our language, in this article in 2009. It was titled Audio-Visual Assessment of Exercise-Induced Laryngeal Obstruction. And the method he described involved continuous monitoring of the larynx during exercise. And I'll show you the method he did in a minute, but I just want to emphasize that ELO literally is a hypernym, an umbrella term. It could include exercise-induced vocal cord dysfunction, of which there are two forms, adduction instead of abduction on inspiration, as you saw on the previous slide. But there are patients that I don't have time to show you have a bilateral adduction of the vocal cords. But they could also have laryngeal malacia that I've already shown you. And there are other causes of paralaryngeal obstruction that are in this article. It's in the Journal of Biology and Clinical Neurology in 2009, entitled Masqueraders of Exercise-Induced Vocal Cord Dysfunction. And so there are other things besides what I'm listing here. I don't have time to go into everything now, but that's important, and it emphasizes the importance of looking. If you're going to you can't make a diagnosis without seeing. And sorry. So what they were doing in this type of study is watching the larynx and scoring it using a complex scoring system. And based on what the score was, they would make a diagnosis of upper airway obstruction, essentially EILO. Sorry. And so I decided I need to learn more about that. And last year I attended this course that National Jewish Health was having. They called it the Exercise and Breathing Conference, the 5th International EILO, ILO, or ILO is inducible laryngeal obstruction. EILO is exercise-induced laryngeal obstruction. So I attended this course in order to learn more about it. And again, what they're doing is continuous laryngoscopy during inspiration. This lady has the laryngoscope fixed through her nose, so it's watching the larynx during the exercise. And
How are you doing, Captain? Thumbs up?
going backwards now. And during that, they're having continuous low volume loops. And this was a slide shown at that meeting that I attended. And they're saying You don't have to have an abnormal flow volume loop to have upper airway obstruction during continuous monitoring with that scoring system. So here's the larynx that they're watching. And so two people are watching the video of this, coming up with a score, and that score is used to define upper airway obstruction. This has become very popular. To use this method, and quite a number of studies, both in Europe and in the United States, have used this method and come up with sometimes some very unreasonable data. So, if you want to determine the cause of exercise-induced dyspnea, this is really the textbook way of doing it.
Are you doing Kathy?
This young lady who is during exercise, and she's measuring O2 utilization, which is important because the O2 utilization correlates with cardiovascular conditioning. CO2 production, heart rate, respiratory rate, flow volume monitoring, maximum tidal volume, minute ventilation, ECG, oximetry, and the ideal thing is to have an arterial catheter in, but in children, we instead, right at the end of the test, got a finger stick, pH and PCO2 as a compromise. And only if we saw flow volume loop data that was showing upper airway obstruction would we then take a look. We would then take a look at the with the laryngoscope what was happening. Any one of various things that could range from vocal cord, two different types of vocal cord dysfunctions. Occasionally, it turns out to be a subglottic stenosis that is exacerbated by exercise. When I was at the University of Iowa, we had, on a regular basis, referrals of patients where the parents and the child were concerned about exercise-induced asthma. Exercise-induced dyspnea. The local physician had generally already tried albuterol and referred the patient because they weren't responding. They certainly thought of asthma first. The median age of these 142 patients were 14 years. Somewhat of a female predominance. They had the symptoms for a long time. The median duration of symptoms was 30 months. So this was not a brand new problem. This was a chronic problem they were having. We had 117 of the 142 where we had complete data on this retrospective look over, over 7 years that we looked. And the diagnosis we came up with was a standard textbook manner of routine evaluation of patients referred to us. We did have 11, even though the patients were screened, and actually asthmatics were identified before, but we did have patients with exercise-induced bronchospasm. We only had 13 with VCD, with vocal cord dysfunction. We had 15 with what we defined as restrictive chest wall changes. It was based on the patients having to use a very high respiratory rate to compensate for a decrease in the predicted maximal volume. We had 2 patients with exercise-induced laryngomalacia, so 2 there and 13 for VCD. We only had 15 patients where extrathoracic airway obstruction was identified. We had 1 patient with exercise-induced hyperventilation. It's a patient who started just breathing very fast right at the beginning of the test, obviously more from anxiety and nerves than anything else. We had 1 patient in this series, and 1 subsequently, who had exercise-induced supraventricular tachycardia. Interesting, he had no palpitations. All he felt, he was a strong American basketball player, and he couldn't last a quarter, and we saw that. And we went over the monitoring EKG, we went over that with our one of our cardiologists, electrophysiology cardiologists, and it was clear that he had supraventricular tachycardia, and even though dyspnea was his only complaint. And we had that in another girl later on after this series. So it happens. It's not common, but if you don't do the right test, you don't see it. The most common thing we had were patients who had no specific abnormalities, but they perceived that the dyspnea from very aggressive physiology, very aggressive exercise, which would cause so much metabolic acidosis that they couldn't compensate with a respiratory alkalosis. And so they got very acidic from normal response. And that acidosis that they can compensate by causing a respiratory alkalosis, because they're already breathing as hard as they can. That causes tremendous stimulation of respiration, which of course they couldn't perform, and they perceived that as inappropriate dyspnea. So, conclusions. Exercise-induced dyspnea is not always asthma, although that's the most common. Treadmill exercise is indicated when other symptoms of asthma are not present and when the bronchodilator doesn't prevent exercise-induced dyspnea. Testing should include pre- and post-exercise spirometry, cardiopulmonary monitoring, and laryngoscopy when there's decreased inspiratory flow to see what the cause of that is. Testing should not include watching a wiggling larynx during continuous observation during exercise. And it doesn't teach you anything. That data you get from that does not provide the cause of dyspnea, despite enthusiasm for it. So that's all for today, and I'll be happy to take questions.
Thank you so much, Professor Weinberger. That was a fantastic presentation. I think we've got time for one question before the break. Lena.
Thank you very much. Do you have a lot of success with voice coaching, or having your physiotherapist help with modifying how they breathe? Have you had lots of success with that in this condition?
Well, in a big category where there's normal physiology, yes, the treatment of that really is coaching, because if you watch athletes I did watch it on TV because a father said his daughter playing basketball had to run up and down. She couldn't stop. That's not what professionals do. They run fast, they stop, they go a little slower, and then speed up again. They learn how to pace themselves. And that's what they have to learn, is how to pace themselves. Some of them, 1/3 of those patients, had decreased cardiovascular conditioning, but 1/3 of them had elite level cardiovascular conditioning, and so some needed to exercise more, get better conditioning, but all of those, over 50%, needed coaching and an understanding of what they were doing, and that predominantly is what we provided.
Fantastic, thank you. I think in the interest of time, we'll have to wrap it up there, but I'm sure any extra questions you could ask Professor Weinberger in the break. And thank you once again.
And just for all speakers, if you could look on Slido, and just in case there are any questions on there, if you could answer those.